Okay, good evening, everyone. Welcome to today's webinar session, which is prepared by SEME and Yetena Weg. Today's topic will be on approach to adrenal mass. First, we'll see the medical part, and next we'll see the surgical part. The first presenter is Dr. Helena Getennet. I think you can hear me. Hello.
Yes, you're audible.
Okay, so the first presenter is Dr. Helena Getennet. She did her undergraduate at Jimma University and her specialty and subspecialty at Addis Ababa University. She has around 10-year experience as internist and almost a 2-year experience as an endocrinologist. She is the founder of SEME and also SEME. She is currently working at St. Peter Hospital. And for all our participants, I need to remind you that there is a link. You should fill your name and email so that you can get the SEME certificate. So now I will leave the space for Dr. Helena to start, and at the end we'll have a Q&A session.
Okay, thank you, Dr. Sarah, for your kind introduction. I would also like to thank the Society for Endocrinology and Metabolism of Ethiopia for giving us the opportunity to present this topic as part of the series of presentations on the second annual conference as part of this privileged series. I would also like to thank Yetena Weg for preparing this platform. So I'll be presenting the medical aspect of the approach to adrenal masses. So adrenal masses are commonly named interchangeably as incidentalomas and adrenal masses. This is because they are commonly discovered incidentally during studies that are done for other purposes, and hence they are named as incidentalomas. These are adrenal mass lesions with size more than 1 centimeter in diameter, and the incidence has markedly increased in recent years.
Sorry, Dr. Helena, can you be near to the mic? The audience are saying you have a distant sound. They cannot hear you well.
Okay. Can you hear me now?
Now it's audible.
Okay. So adrenal masses are commonly discovered incidentally, and hence they are named as incidentalomas. These are adrenal mass lesions greater than 1 centimeter in diameter, and the incidence of incidentalomas has markedly increased in recent years because of the widespread use of imaging scans. So with regards to the prevalence, autopsy studies indicate that the prevalence of incidentalomas is around 2 to 3%, but this is variable, and prevalence is known to be higher in those older individuals and those individuals who have metabolic comorbidities. So when we see the causes for these adrenal masses, recent publications indicate that majority of these adrenal masses are benign and non-functional, and out of the functional ones, the commonest ones are adenomas due to mild autonomous cortisol secretion, which is also referred to as subclinical Cushing, and the rest due to overt Cushing's, Aldosteronomas, and malignancies. So there is limited local data with regards to the prevalence as well as the cause of adrenal incidentalomas, but there was one publication by Professor Johnson. It was a retrospective study that was done at the Kurambesa Hospital, which looked into 40 patients who underwent adrenalectomy, and it identified that Cushing disease was the commonest reason for adrenalectomy, followed by Pheochromocytoma, and this is more or less similar to the international data with regards to the cause of incidentalomas. So in 10 to 15% of cases, these masses tend to be bilateral, and even though there are multiple proposed causes for bilateral masses, it's always mandatory to exclude congenital adrenal hyperplasia, malignancies, and infiltrative diseases, as these are the commonest cause of bilateral masses. And all patients with bilateral adenomas should be screened for adrenocortical hyper or hypofunction. And it's always advised to treat each of these bilateral masses individually, because one side of the mass can be hyperfunctioning or hypofunctioning, while the other mass is non-functional. And always it's good to exclude adrenal insufficiency, particularly in case of metastatic diseases, infiltrative diseases, and hemorrhage. So in the approach to the clinical evaluation of a patient presenting with adrenal incidentaloma, the two things we need to look into is, one, is it malignant? And the second thing is it functional? So in the evaluation for malignancy, we should note that malignancy is an uncommon cause of adrenal incidentaloma in a patient who do not have a known diagnosis of cancer. And the prevalence of primary adrenal carcinoma ranges between 2 to 5%, and now to 2% of cases, this can be due to metastasis to the adrenal glands. So size and imaging characteristics are critical to define malignancy in incidentalomas. So when we look into size, size became an important modality in the previous studies. So one of these important studies was the study that was done by the National Italian study group of adrenal adenomas, which was one of the largest studies that were done. And the finding from these studies concluded that in 90% of masses, 90% of adrenal carcinomas had size more than 4 centimeters diameter. This not only had a diagnostic significance, but it also had a prognostic significance, in that smaller masses were associated with a better outcome, and larger masses were associated with a worse outcome. So a 4 centimeter cutoff had a 93% sensitivity, but it lacked specificity, because up to 76% of these large masses were still benign. So this led to the need for incorporation of other imaging phenotypes and the change in size over time on top of the size criteria in order to define malignancy. So when we say imaging phenotype, this is based on the fact that a benign adenoma is lipid rich, making it low dense radiologically, and this measure of density based on unenhanced CT is called as attenuation. So the quantitative measure of attenuation is called as Hounsfield unit, which is also abbreviated as HU. So benign adenomas, because of their high lipid content, they are radiologically less dense, meaning that they have low attenuation. And so as a measure of attenuation, an HU unit of less than 10 is in nearly 100% of cases, it defines benign adenomas. But still, 1/3 of benign adenomas do not have a high lipid content, meaning that they can have an attenuation value above 10 HU. So the imaging characterization of malignancies was one of the major changes that was done in the revised 2023 ESC guideline. So as you can see, in the previous guidelines, a size more than 4 centimeter in diameter, low attenuation less than or equal to 10 HUs, and a homogeneous appearance was used to define a benign adenoma. But taking into the fact that most benign adenomas, more than 70% of cases, can have a size more than 4 centimeter in diameter, the 2023 ESC update excluded the size criteria, and it only used the homogeneous appearance and the attenuation value of less than or equal to 10 HU on unenhanced CT to define a benign adenoma. So on the other side, a homogeneous appearing adenoma with high attenuation value above 20, or heterogeneous mass which had a size more than or equal to 4 centimeters is defined to be highly malignant. So the option, the management option is either to proceed directly to surgery, but there are mass lesions that lie in between these two clear categories of benign and malignant. So one group of these lesions, they have smaller size, somehow higher attenuation, a value between 11 to 20, and homogeneous appearance. So these adrenal masses are still considered to be benign. So you can either choose to re-evaluate with an enhanced CT after 12 months or do additional imaging. But for the other group of masses which have heterogeneous appearance, but they are smaller, they are homogeneous, but they have a high attenuation, or they are homogeneous, but they have a moderate attenuation, but a larger size. These tumors are referred to as indeterminate tumors, and the likelihood of these indeterminate tumors of being malignant is somehow higher. So in this case, either immediate surgery or immediate additional imaging is decided. So when we say additional imaging for indeterminate masses, this uses contrast enhanced CT, and this is based on the contrast washout characteristics of benign adenomas versus malignant ones. So 10 minutes after contrast is administered, a benign adenoma typically demonstrates a rapid contrast washout of more than 50%. So this is 100% specific and sensitive for a benign adenoma, while a malignant lesion would have a slow contrast washout of less than 50% after 10 minutes of administration. So even though CT scan is the preferred imaging modality of choice, MRI can be used in some group of individuals, particularly pregnant mothers, children, and adolescents in whom CT scan is not recommended. And similar CT characteristics would apply for benign and malignant adenomas, meaning that a benign adenoma would have a mild enhancement and a rapid washout of contrast, while a malignant lesion will have a slow contrast washout with marked enhancement. PET scan can also be used, particularly in those patients in whom who have a prior history of malignancy and recurrence is considered, or when post-contrast studies are still inconclusive with CT scan. So to summarize the imaging characteristics of adrenal masses, benign adenomas typically have a low attenuation on unenhanced CT with AQ less than 10, and they also demonstrate rapid contrast washout of more than 50% after 10 minutes, while Pheo and adrenal malignancies, they have a high attenuation value above 20, with delay in contrast median washout of less than 50%. So the other question is there a role for final lab aspiration? So FNAC cannot really distinguish benign adenoma from malignant ones, but it can be used to distinguish between primary adrenal tumor and a metastatic tumor. But still, this is not recommended unless it's expected to change the overall management of the patient, meaning that, for instance, if a patient has a primary malignancy with no other known site of metastasis and is discovered to have an incidentaloma, which is suspicious for malignancy, then confirming that this is a metastatic lesion would change the management of this particular case, and FNAC might be considered. But FNAC should only be done after biochemical tests exclude pheochromocytoma in order to avoid a pheo crisis. So the other evaluation is for hormonal secretion. So 10 to 15% of adrenal adenomas can secrete excess hormones. So appropriate case detection tests are recommended if patients have clinical signs or symptoms of excess adrenal function. But all patients who present with adrenal incidentalomas should be tested for subclinical Cushing's and Pheochromocytoma, despite the presence or absence of clinical symptoms. So for subclinical Cushing's, the reason for a screening of all incidentalomas is one, as you saw earlier, it is the commonest functional cause of adenomas. And the second reason is that patients with subclinical Cushing's, even though they lack a clear clinical stigmata of Cushing's, they still have a high morbidity and mortality associated with the excess cortisol. And with Pheochromocytoma, as mentioned, nowadays they are being discovered in the pre-symptomatic stage, and because of the high mortality associated with the Pheo crisis, it is recommended that all patients with incidentalomas should be tested for these two disease entities, despite the presence or absence of clinical symptoms. So when we see subclinical Cushing's, this has been frequently renamed, and according to the 2023 ESC update, it is now renamed as mild autonomous cortisol secretion. And as you can see, it is the commonest cause of secretory or functional adrenal adenomas. It is, of course, ACTH independent, and patients lack the usual stigmata of overt Cushing's, but in up to 40% of patients, even though they lack a clear stigmata of Cushing's, they still have the metabolic complications of Cushing syndrome, including hypertension, diabetes, prediabetes, and a high incidence of vertebral fractures is also noted in these individuals. So in all patients with adrenal incidentalomas, the 1 milligram overnight dexamethasone suppression test should be done. And the second major change in the 2023 updated ASC guideline is with regards to the interpretation of the dexamethasone suppression test. So as you can see in the previous version of the guideline, autonomous cortisol secretion was excluded if cortisol level after 1 milligram dexamethasone suppression was less than 1.8 microgram per dl, and it was confirmed if cortisol level was above 5, and anything in these two between was labeled as possible autonomous cortisol secretion. But in the 2023 update, it clearly defines mild autonomous cortisol secretion with cortisol values above 1.8 microgram per dl. So this is a major update in the recent guideline. So once mild autonomous cortisol secretion is diagnosed, then further demonstration of ACTH independence can be done. So this is done, one, by determining serum ACTH level, which is expected to be undetectable in this case. You can also do adrenal androgen levels like dihydroepiandrosterone sulfate. Again, this will be undetectable because it is ACTH dependent by nature, and a clinically significant glucocorticoid secretory autonomy can be described by the high dose, that is 8 milligram dexamethasone suppression test if the morning cortisol level is above 5 microgram per dl. So one controversy is whether there is a need for further biochemical screening once overnight dexamethasone test is negative. So there have been different recommendations by different guidelines. So the AAC guideline recommends that screening should be continued annually for the first 4 to 5 years, based on the fact that up to 1/3 of one-third of non-functional tumors and subsequently develop mild autonomous cortisol secretion during the follow-up period of 3 years, while the European Society of Endocrinology guidelines don't recommend further follow-up biochemical testing. So there is a need of long-term studies to come up with a clear recommendation with regards to screening. So in those patients in whom mild autonomous cortisol secretion has been documented, is there a need to do adrenalectomy in all of these patients? Again, there is no solid recommendation in this aspect because of the lack of randomized studies, but the general consensus is that adrenalectomy might be considered for younger individuals with age less than 40, or those who have comorbidities associated with glucocorticoid excess, mainly the metabolic complications and osteoporosis, and in those in whom glucocorticoid secretory autonomy has been well documented. So in this group of individuals, adrenalectomy might be considered. So it's very important to provide perioperative glucocorticoid coverage in order to avoid adrenal insufficiency intra and postoperative. So after adrenalectomy, improvement is expected in terms of weight loss as well as the metabolic parameters, as well as in terms of normalization of the markers of bone turnover. So the second cause of functional adenoma is pheochromocytoma. Its overall incidence is very low. It's around 3%. But as I mentioned earlier, because of the widespread use of computed imaging, Pheo is nowadays being discovered in the pre-symptomatic stage. So all patients need to undergo biochemical screening with either plasma or 24-hour urinary fractionated methanogen levels. And the difference between these two tests is that the plasma fractionated methanogen level determination, it lacks specificity, meaning that a number of patients can have a false positive results. So this test should be limited for those individuals in whom the probability of pheochromocytoma is high based on imaging characteristics. So a mass lesion that appears to be highly vascular, which has a high attenuation above 50, or it has a slow contrast washout. This is a mass lesion which is it has a high probability for Pheo. So plasma fractionated methanogen level can be done for these individuals. Otherwise, in those in whom the probability of Pheo is low, the 24-hour urinary methanogen should be determined. And it's good to note that there are a number of drugs that could give a false positive result. So medical preparation for surgery is very critical in order to avoid the high surgical mortality rate associated with untreated pheochromocytoma. So a combined use of alpha and beta adrenergic blockers, as well as calcium channel blockers and tyrosine has been used. And alpha blocking agents should be administered 10 to 14 days preoperatively, but in some cases, a longer duration of treatment should be used, like in case of myocardial infarction or catecholamine-induced cardiomyopathies. Phenoxybenzamine is the commonly used alpha adrenergic blocking agent. More alpha-1 selective agents like trazosine, perazosine, and doxazosine can also be used. So the target blood pressure is less than 120 by 80 seated, but the systolic blood pressure should be kept above 90 standing in order to avoid orthostasis. But this blood pressure cutoff point should be individualized based on comorbidities. High sodium diet should also be part of the medical treatment, and this ideally should be started on the second or third day after alpha blockers have been initiated. So the main reason why we need this high sodium diet is in order to reverse volume contraction that is associated with the alpha adrenergic blockage. But this needs caution, particularly in patients with congestive heart failure or renal infections. The other agents that we can use to further control blood pressure and catecholamine-induced is beta adrenergic blockers. So these agents are initiated after ensuring that adequate alpha blockage has been done, and this typically occurs 2 to 3 days prior to surgery. Again, initiation of beta blockers requires caution because after initiation, some patients might decompensate because the catecholamine-induced cardiomyopathies might unmask after initiation of beta blockers. So it is recommended to start a low dose of shorter acting beta blocker, ideally propranolol, and later on shift to higher dose of long-acting beta blockers after ensuring that the patient has well-tolerated propranolol. And dose of beta blockers can be titrated with a goal heart rate of 60 to 80 beats per minute. Calcium channel blockers can be used if blood pressure is not well controlled with alpha and beta blockage. Nicardipine is the most commonly used calcium channel blocker, but there are limited data on whether we can use the locally available calcium channel blockers. But there was one recent publication in 2021 in the Journal of Clinical Endocrinology and Metabolism. So it was a study that was done to evaluate efficacy of amlodipine as compared to prazosin, and this study concluded that amlodipine was as effective as prazosin in terms of perioperative blood pressure control. Tyrosine is another agent that can be added on top of the other agents. So this is a catecholamine synthase inhibitor, but again, the use of tyrosine should be limited because of its high side effect profile, which includes extrapyramidal side effects. So parenteral medications can be used, particularly intraoperative. So fentoramine, nitroprusside, nicardipine can be used for blood pressure control, while esmolol and lidocaine can be used to treat arrhythmias. So after adrenalectomy, biochemical testing should be performed 2 to 4 weeks after surgery. But pheochromocytoma is associated with a high recurrence rate after adrenalectomy, even decades after surgery. So annual biochemical testing is required lifelong. The other secretory tumors are aldosteronomas. So aldosteronomas are the rarest cause of functional adenomas. So all patients who have hypertension and adrenal incidentaloma should have biochemical screening for primary aldosteronism, despite the presence or absence of hypokalemia. This is because a majority of patients with primary aldosteronism may not really have hypokalemia. So the diagnostic approach would be to do the case detection test first, followed by confirmatory test, and later on subtype evaluation test. So as a case detection test, the plasma renin activity and plasma aldosterone concentrations are determined. And if both plasma renin activity and plasma aldosterone concentrations are high, or if the ratio is less than or equal to 10, then this excludes primary aldosteronism, and patients should be worked for a secondary aldosteronism. But if the ratio is above 20 and plasma aldosterone concentration is high, above 15 nanogram per dl, then this means a positive case detection test for aldosteronism, and further confirmatory test should be done. But it's important to note that in addition to a high plasma aldosterone to renin ratio, there should be documented high plasma aldosterone concentration. This is because the ratio is denominator dependent. So change in plasma renin activity, be it from the different assays used, can give a false positive or a false negative result. The other thing is the values of plasma aldosterone and renin are reported in different units. So proper calculation should be done to convert the units before the ratio is calculated. So again, we need to avoid drugs that could give a false negative result. So the common drugs are the mineralocorticoid receptor antagonists and ACE and ARB, ACE inhibitors and ARBs. So this should be avoided. And if already started, then MRH should be discontinued for at least 6 weeks before the biochemical testing. But if plasma aldosterone concentration is high, particularly if it's above 10 nanogram per dl, then this excludes any false positive testing, because there is no medication that can cause a false positive result with this degree of aldosterone elevation. So once the case detection test is positive, we proceed to the confirmatory testing. So this involves one, the oral sodium loading test. Again, this is a highly sensitive and specific test. So we subject patients to a high sodium diet for 3 days, and this is followed by a 24-hour urinary aldosterone determination at the 4th day. So this is expected to suppress endogenous aldosterone secretion, but if urine aldosterone levels are more than or equal to 12 microgram 24-hour urine samples, then this is a confirmatory test for primary aldosterone. The other confirmatory tests are the intravenous saline infusion test and the fludrocortisone suppression test, which have a similar concept behind, that is, sodium loading should result in suppression of endogenous aldosterone, but if a higher levels are found on subsequent testing, then this is confirmatory to primary aldosteronism. So again, if confirmatory tests are positive, we proceed to subtype studies. So CT tomography is used with this regard. So this is used to distinguish between primary aldosteronism secondary to an adenoma with a bilateral hyperplasia. So the other indication for CT scan would be to exclude carcinomas. But when CT scan is inconclusive, that is when if it appears normal or it shows bilateral abnormalities and it's not clear which side is secreting excess aldosterone, or it is unilateral but the patient is above 35 years old, then adrenal venous sampling should be used to confirm or lateralize the lesion, but this should be done only in patients in whom surgical management has already been decided. So adrenal venous sampling is used to compare aldosterone levels in the IVC and between the right and left adrenal veins. So this should be done in experienced hands, and it should only be done in surgical candidates who don't have an obvious lesion on CT, or who have a typical unilateral lesion, but the patient has age above 35. And the reason why we need to do AVS in individuals above 35 years is that there is a high incidence of benign adenomas in this group of individuals, and we really need to identify or make sure that it is this incidentaloma that is producing excess hormones, because there have been case reports showing that while a patient is having incidentaloma, it was rather the normal appearing adrenal gland which was secreting excess aldosterone. So lateralization is important in those individuals aged above 35 before surgery is done. So ABS requires measurement of cortisol in order to ensure proper catheterization, and it then indicates lateralization if aldosterone to cortisol ratio is above 2, if the ratio is increased by at least 2 folds amongst the two sides, the right and the left side. So to summarize the sometime testing, adrenal scan demonstrates either normal appearing glands or minimally nodular glands, and it's not clear which side is producing the excess aldosterone. So we need to decide whether we are going to perform surgery or treat with pharmacotherapy. If surgery is decided, then lateralization is mandatory, so ABS should be done. In other case, if the CT demonstrates a typical adenoma, unilateral adenoma, then we again need to decide whether we are going to manage surgically or medically. So in those individuals in whom surgery is desired, if age is less than 35, we can proceed directly to surgery because the incidence of benign adenomas is low. But if age is above 35, then ABS and lateralization should be done prior to surgery. So when we see pharmacotherapy, can be provided typically with MRAs, and it should be integrated with lifestyle modification because this contributes to the success of blood pressure control. And the target will be to achieve a high normal serum potassium without the need for PCL supplementation. So spironolactone is the commonly used drug, and upon initiation of spironolactone, hypokalemia improves rapidly, but it takes up to 8 weeks for blood pressure to normalize. So it requires monitoring of serum potassium for the first 4 to 6 weeks. And we also need to watch for adverse effects of spironolactone, particularly in male patients. Eplerenol, which is a more selective MRA, can be used. It's particularly important if we encounter side effects of spironolactone. And the other sodium channel blocker that can be used in this case is amiloride. But if patients are found to have glucocorticoid remendable aldosteronism, then this is by definition ACTH-dependent aldosteronism. So these individuals would rather be treated with chronic glucocorticoids in order to achieve ACTH suppression. So if surgery is done, then plasma aldosterone concentration should be measured 1 to 2 days after surgery to confirm biochemical cure. And postoperatively, both the dose and number of antihypertensive medications should be decreased by at least 50%. And AC inhibitors and ARBs in particular need to be discontinued first because of the risk of hyperkalemia. So serum potassium levels should be monitored weekly for the first few weeks, and patients should also be advised to have a high sodium diet in order to avoid volume contraction. So hypertension might take up to 3 months to improve, while some degree of improvement in terms of blood pressure control is seen in nearly all patients who undergo adrenalectomy. Cure rates for hypertension are low. It is between 30 to 60%. And this is because of the coexistence of primary hypertension in some of the individuals. So to summarize my talk, the key points would be One, imaging characteristics is key to distinguish malignant lesions from benign ones, and a combination of size, attenuation or non-contrast CT, and contrast washout characteristics are the key imaging features that are used to differentiate between malignant and benign lesions. The other point is that all patients with incidentalomas should be screened for mild autonomous cortisol and PO, and perioperative glucocorticoid coverage is really mandatory to avoid adrenal insufficiency for those with subclinical Cushing's. And we need to optimize medical treatment prior to adrenalectomy in patients with Pheochromocytoma in order to avoid the high morbidity and mortality associated with the Pheo crisis. And because of the high recurrence of Pheochromocytoma after adrenalectomy, there is a need for annual biochemical testing lifelong. And for those individuals who present with hypertension and incidentaloma, biochemical screening should be done as a case detection test for primary aldosteronism. This should be followed by a confirmatory and subtype studies. So I would really want to thank all the participants in this session. And again, I would like to thank the Society for Endocrinology and Metabolism of Ethiopia for giving us the chance to present, and Yetena Weg for preparing this platform. Thank you.
Okay, that was a nice presentation by Dr. Helena. So nowadays, incidentaloma is increasing because of increased doing of imaging for different reasons. So she has told us how to approach a patient who has incidentaloma. So the most important things are, so is it malignant or not? And the other is it functional or not? And depending on that, how to manage the patient, and also for the functional ones, how to screen them. So we will thank our first presenter, and then we will continue with the next presenter. So the next presenter is Dr. Marta Said. She's an assistant professor of general surgery. She attended her undergrad at Mekelle, and she has attended also her specialty at St. Paul. She is currently a fellow of endocrinology and breast surgery at St. Paul Millennium Medical College, and she will continue with the surgical management of adrenal mass. And at the end of the session, we'll have a Q&A. You can also drop your questions for Dr. Helena at the chat box, and at the end we'll discuss.
Thank you, Dr. Saba, for the introduction. And thank you everyone for joining us for this session. So the session is basically the management of adrenal mass, and majority of the concepts regarding the diagnosis and medical treatment has been well described by Dr. Helena. So I will just add some few points regarding the surgical management of adrenal masses. So this will be my outline. So I don't have any disclosure. So as a surgeon, regarding the surgical treatment of adrenal masses, the thing that we consider to operate or to do adrenalectomy in this patient is basically, like Dr. Helena has mentioned, we see the functionality of the tumor. The functionality can be an overt functional or an overt secreting tumor, or it can be a subclinical functioning incidentaloma, or we consider the risk of the indications for any sign of malignancy in the clinical and imaging findings. The other thing we consider is the size of the tumor, because the larger the size is said to be, the larger the risk of, the higher the risk of malignancy. So surgical candidates will be patients who has the functional lesions, depending on their specific indication for surgery, patients who had malignant lesions, or patients who had a higher size in the size of the adrenal mass. This cut point of the size of the adrenal mass has a different size in different guidelines, but basically most of the guidelines use the cut point of around 4 to 6 centimeter of size. So in general, so many research has been done previously to assess patients, to follow patients, either to follow patients or to do surgical treatment, especially in those patients who have no overt malignant sign or who have no overt symptoms. And on this research data, I have tried to see majority of these patients after follow-up of more than 2 years and 3 years and 4 years. None of the patients had risk of malignancy, but a significant number of patients developed functional tumors like Cushing syndrome, Pheochromocytoma, and significant number of patients also had an increment in size. So in the era of lap adrenalectomy, in the current era when we can do adrenalectomy with less morbidity and mortality, patients who had a subclinical, also subclinical incidentaloma are recommended to do surgical treatment, because these patients in a long run they will be have a decreased risk of cardiovascular risk or endocrine damage. If we do adrenalectomy, they will have a lower risk of these complications. When you think of a surgical treatment of an adrenal mass as the preoperative, we have so many preoperative concerns, because these tumors can be functional tumors like Pheochromocytoma, Cushing, or primary aldosteronism. So we need a critical goal-setted pre-op evaluation of this patient with each perspective department. So what we do in our practice is basically, if you have a diagnosed Pheochromocytoma patient, we always consult with our cardiology colleagues. We'll also consult with an anesthesiologist, and also in our endocrinologist in the internal medicine side, so that we can avoid the intraop labile hypertension, labile hypotension, labile blood pressures, and also we can decrease the mortality regarding to the surgical procedure. So I'm not going to go through all the preparation of this patient, because of Dr. Helena has mentioned majority of the drugs, their outcomes, and so on to prepare this patient. So basically, on Pheochromocytoma, we need to have a thorough cardiac evaluation, a thorough organ function evaluation with the anesthesiologist, with the cardiologist. We need to have an adequate sympathetic blockage with alpha blocker and beta blockers. We need to correct our intravascular volume, and we have to evaluate also for other heritable lesions before we do our surgery. In our case, we do minimum of neck ultrasound and investigation for hyperparathyroidism, because to assess patients who has main syndrome in our setup. Regarding Cushing syndrome, the same, it has been well described. We restrict cortisol secretion, and we treat any consequences that this high cortisol level result, like we need to have a good glycemic control, we need to treat the hypertension, and we need to have also a prophylactic anticoagulation before the surgery, so that this patient won't have a DVT postoperatively, and steroids also has to be done for this patients. The other thing, for wound healing and post-op recovery, sometimes these patients also will benefit from vitamin A supplementation 1 week prior to the surgery. Regarding primary aldosteronism, the most important thing that we need to correct preoperatively is the potassium deficit, like it has been described earlier with Cambios spironolactone or potassium supplementation. We have to correct this potassium deficiency. And like it has been described earlier, we need to have also arteriovenous sampling to localize this primary aldosterone secretion lesions in the adrenal. So after we do our preoperative evaluation, the next step will be which surgical approach will be appropriate for our patients. So in general, we have two options of surgical treatment. We have the open and the laparoscopic. Of course, if you add robotic, it will be 3, but we'll discuss mainly on the open-end laparoscopic approach of adrenalectomy. So in general, currently the standard surgical treatment for adrenal is a laparoscopic approach because of those known reasons: less incision, less pain, less hospital stay, and fast recovery, less bleeding. Due to all those advantages of laparoscopic surgery, currently the standard of care for laparoscopic for adrenal surgery is laparoscopic approach. So there are so many laparoscopic approach. The posterior retroperitoneal approach is said to be currently the treatment of choice because it has, we don't enter to the peritoneum. That will allow us for the patient to recover fast because there is no bleeding, there is less risk of ileus, and the procedure will be fast. So currently posterior retroperitoneal approach is said to be the best in this patient. But if you have larger lesions, more than 10 centimeters, if you have local invasions of malignant adrenal tumors, it's better to do an anterior transperitoneal approach. There are also a flank and lateral approach. We have a thoracoabdominal approach for tumors which are very big and for tumors who have IVC thrombus to access the proximal intrathoracic part of the IVC. And other options, recently added options, are a single site LACE adrenalectomy and hard-reported assisted laparoscopic adrenalectomy has been come to the picture. When it comes to the open surgical approach, currently, like I said, laparoscopic is the best, but in time open is reserved for those patients who have very large lesions, more than 10 centimeter lesions with invasion of the local organs, invasion of the surrounding structures that we cannot treat with laparoscopic approach. And also patients who have contraindication for laparoscopic approach, we will do open surgical approach. So again, this open surgical approach, we have around 4 options. We have the anterior option, the posterior option, we have the flank option, and thoracoabdominal surgical options, depending on the type of the functional tumor, the size of the tumor, the BMI of the patient, and also the experience and the expertise of the surgeon. We have these options. So, like I said, in malignant lesions, especially adrenocortical carcinomas, there has been, previously it has been said, every adrenocortical carcinoma has to be treated with open surgery because the conversion rate of this surgery to open is very high. But currently, I have tried to revise some papers. Most of this, all of them, they showed similar outcome of oncologic outcome of adrenocortical carcinoma after both laparoscopic and open surgical approach. They have both same overall survival and disease-free survival. So in general, if we keep or if we preserve the oncologic principle of adrenalectomy, we can use either laparoscopic and open approach if the tumor doesn't involve the surrounding neighboring organs and if the tumor size is not that big, depending on the surgeon's experience. So the other issue in adrenal surgery is the oncologic principles when you have a malignant lesions. So if you have a malignant lesions, we need to have a wide surgical exposure with good vascular control, and tumor has to be removed with associated surrounding lumbosacral lymphadenopathies. And if there is adjacent organ involvement, it has to be resected in block without rupturing the capsule. We need to keep the capsule intact to avoid an intraperitoneal tumor spillage. So the other surgical term that we use in adrenal surgery is the partial adrenalectomy, which is what they call it cortical sparing adrenalectomy. The advantage of this adrenalectomy is basically to avoid adrenal injections and to avoid lifelong supplementation of steroids in those patients for whom we did bilateral adrenalectomy, or for those patients we do a unilateral adrenalectomy with a suppressed contralateral adrenal gland. So what we do in this patient is basically resecting of the tumor, the adenoma, or some lesion in the adrenal without mobilization of the whole adrenal gland. And in general, if we keep around 20 to 30% of one side gland, we can keep the functional outcome of this patient, so we can avoid a lifelong supplementation of this corticosteroids in this patient. So this is the case that we have operated recently. This is a 37 years old male patient who presented with persistent high blood pressure. And also he has also a history of old stroke, and on diagnostic investigation, he had a high metanephrine and he had clear diagnostic laboratory investigation for Pheochromocytoma. And we have discussed this patient with our MDT team, and we admit this patient 10 days before our planned surgical day, and we did the pre-treatment with those alpha blockers, phenoxybenzamine. We give a propranolol at around 3 days, after 3 days of alpha blockage, and the patient had been in the ward with the pre-medications. We did a full organ function tests, and after adequate blockage, symptomatic blockage, we took this patient to the OR, and we approached the lesion. It was the right side on imaging. It was the right side, around 5 by 4 centimeter right adrenal mass, invading the encasing the IVC and also the right renal vessel. So we approached this patient through the right subcostal incision, which is a type of unopen intraperitoneal approach. So during this approach, what we did was, after entering the peritoneum, we mobilized the right hepatic flexure, but flexure of the colon to the left side. That means the Cattle's maneuver, and we also did a cauterization of the duodenum so that we can have direct access to the IVC. Then after that, this was the tumor. This is the IVC, and this was the renal vein. It has the tumor has an attachment to the IVC and also the renal vein, but it was not that much an dense adhesion. So we opened the peritoneal reflection around between the IVC and the mass, and we accessed the tumor. Then after that, after adequate vascular control, regarding the principle of right adrenalectomy, we exposed or we dissected the critical area of dissection in the right adrenalectomy. That means the space between the IVC and the left renal vein, so that in between that triangle, that means around here, we can directly access the right adrenal vein. So after we ligated that, we gently released the adhesion from the IVC and the left renal artery, and while after ligation of the vein and after dissection of the mass, the patient had very labile blood pressure. It comes down to very hypotensive. Then again, after a few minutes, it goes very high. It has thanks to our anesthesiologist, it was critically and very well controlled. Then the mass was dissected out, and this was the size of the mass. And postoperatively, after 2 weeks, the patient came to the referral clinic. He was doing fine. He had no any hypertension. He was off his antihypertensive agent, and he's recovering. The biopsy result is still not collected. So like I said, in our patient, the intraop management of this patient is very critical and difficult because they have very labile blood pressure intraop, even in the presence of adequate pre-op blockage. So we have to be ready preoperatively for this patient. We need to have a large ball peripheral central venous catheter or arterial catheter, arterial line, so that we can have a direct hemodynamic evaluation of this patient. So if the drug that we can use in TROP is, if you have hypertension, we can use ismolol or metronidazole. If you have hypotension, we can use either phenylephrine, ephedrine, or dopamines. And we can also have an arrhythmia in TROP. So the most common cause of an arrhythmia in this patient in TROP is tumor manipulation. So the best treatment will be discontinuing the tumor manipulation so that this arrhythmia can stop. But in some patients, even after discontinuation of tumor manipulation, the arrhythmia can persist, so that sometimes we might need some pharmacological drugs to control the arrhythmia. The other intraop challenge is during Cushing syndromes, we need to do a glucocorticoid replacement started during the study, should be started during the surgery. This is the operation notes, which was done on 1961. I brought this just to show you how the surgeon at that time described the intraop challenge of doing this procedure. You can have the time to read it. So after surgery, we have to follow this patient postoperatively. So patients for whom we do adrenalectomy for Pheochromocytoma, commonly in our practice, we at least put them for 24 hours, either in the ICU or in the HDU unit, so that we can control the hypotension, the hyperglycemia in this patient postoperatively. So commonly, most of them, after 24 hours, they don't need any additional days of ICU admission. They'll have a normotensive state after 24 hours, majority of them. So after that, we can follow them with baseline 24 hours metanephrine and catecholamines 2 weeks after surgery. Then to assess for any recurrence, we need to do an annual plasma metanephrine test. And this annual test can be every 6 months for those with syndromic main syndrome patients. So recurrence can also happen in these patients. So that's why we need an annual plasma metanephrine test. After we do surgery for Cushing syndrome, we need to do a glucocorticoid replacement for this patient, even if we do a unilateral adrenalectomy, because the contralateral can be also suppressed because of the pituitary adrenal axis suppression. So we need to replace this patient with glucocorticoid replacement. This replacement can be even up to 1 year. And we need to replace also this supplement with vitamin A. And regarding the outcome of this Cushing syndrome after adrenalectomy, most of the manifestations in the early 6 weeks, they can disappear. The minor symptoms like the fatigue and so on. But the obesity, the cutaneous manifestations might take a while to recover, the cushinate appearance and so on. They might take up to 1 year to reverse. And regarding the hypertension, if the cause is adenoma and if the adrenalectomy is done for adenoma, majority of them, almost 100% of them, get a cure from the hypertension. But in some patients, hypertension can be persistent, which is around 30%. And diabetes can be also persistent in around 20% of the patients. So after that, these patients need also periodic checkup and strict follow-up postoperatively. So the post-op management after surgery for primary aldosteronism is mainly focusing on maintaining a high sodium diet, maintaining a normal calcium, normal level of potassium state, treating the hypo and hypocalcemia, hyper and hypercalcemia. And in this patient, majority of them, either we do a medical therapy for a bilateral lesion or a surgical therapy. The outcome is very favorable. So they have a very good outcome. So the outcome is mainly assessed by the level of aldosterone and hypokalemia around 2 months of time, which is corrected in almost 90 to 100% of the patients. And only 1/3 of but regarding the blood pressure, only 1/3 of the patient, around 30% of the patient will have a normotensive, will be a normotensive after adrenalectomy. So we have to counsel our patient that the surgery will solve the hypertension. So only 30% of the patients will recover or have a complete cure of the hypertension. But we can see, like Dr. Helena has mentioned, we can have an improvement in the hypertension. We can have a decrement in the dosing and decrement in the antihypertensive number of antihypertensive agents in this patient. So this happens in almost all of them, almost 98% of them. So the outcome is very good, very favorable. After surgery, for adrenocortical carcinoma, we need to follow this patient postoperatively. Sometimes this patient can have septic-like symptoms postoperatively because of tumor manipulation, resulting in release of the tissue necrosis factor, which patients will have septic-like symptoms without any positivity in the culture tests. So we treat these symptoms symptomatically. We treat them, we give the patients stress dose steroids, and the outcome of this patient, even if it depends on the stage of the disease, the median survival rate is mainly around 29 months. So apart from the specific concern, specific complications that I have mentioned after surgery, we can have a general complications like hemorrhage, intrahemorrhage. It could be from the adrenal vein, it could be from the lumbar and other hepatic. If you do mobilization of the liver proximal, we can have bleeding from the middle hepatic vein. And while we do a left side adrenalectomy, we can have a pancreatitis or pancreatic fistula, pancreatic cirrhosis. We can have pneumonia, and if it's an intraperitoneal approach that we used, we can have prolonged ileus, post-op collection, and we can have also injury to the adjacent structures during the procedure. So in conclusion, there are so many approaches to do an adrenalectomy. It can be laparoscopic or open, but the patient condition, the clinical presentation, the BMI, the obesity, the BMI of the patient, the size of the tumor, the experience of the surgeon will be the most of the things that will decide which type of surgical approach that we need to do. And the outcome is also depends on the type of the functional tumor, the type of the malignancies that we are dealing with. So these are my references. Thank you so much. Thank you, everyone.
Thank you, Dr. Marta, for your great presentation on the surgical management of adrenal masses and also incidentalomas. She has told us what the indication for surgery and also pre-op management for functional adrenal masses, and also types of surgeries, which approaches are best, and postoperatively how to follow the patient, and also which treatments are mandatory, and also the complications of surgical management of adrenal masses. She has told us in her presentation. Thank you for the two presenters. Now, so we will have the Q&A session. So if you have any questions, drop it in the chat box. And I have, I think, at least two questions till now. So the first question, you can answer, any of you can answer, either Dr. Helena or Dr. Marta. Is lateralization done? That is for primary hyperaldosteronoma. Is it done here? And who should do it is the first question. The other question is, I think, for Dr. Helena. So for this is also for primary hyperaldosteronoma. Do we need always confirmatory tests, or is there a place of going without confirmatory tests for lateralization?
Thank you, Dr. Sabo. So I would first answer the second question. So is there always a need to do confirmatory tests for primary aldosteronism? the answer is not always, because in those cases in whom the case detection tests have clearly demonstrated aldosteronism, and in those who have clinical parameters, like those who already present with hypertension and uninduced or unprovoked hypokalemia, or those who have a very high primary aldosterone, plasma aldosterone level above 20 nanogram per dl, we may not need to do confirmatory tests. But regarding lateralization, yes, if we plan surgery, then we need to do this lateralization test for individuals aged above 35, or for those who have indeterminate imaging or CT features. So regarding the first question, that are we doing AVS in our country, or who should be doing it? So the literature described that it should be done under experienced interventional radiologists. But is it being done in this country? I'm not sure. I would have to ask my seniors to respond to this question.
Dr. Marta, do you have any reflection on the lateralization? Is it done here or not?
So far in my from my reading, like Dr. Helena said, it's basically done by interventional radiologists. Previously, it had a higher mortality ratio, it has a higher bleeding from the from the adrenal veins, because there was not a lot of experience regarding this procedure. But currently it has a lower mortality, lower complication rate. So majority of the tests are being done by interventional radiologists, but I'm not sure it's whether it's currently practiced in our country or not.
Okay, thank you. I don't see other questions, but for discussion purpose, maybe any of you can answer it. So do we need always adrenal protocol for diagnosis of incidentaloma, or can you use so a patient can have abdominal CT for any purpose and it can show adrenal mass? So do we need to do adrenal protocol always?
Thank you, Dr. Saba. So if this, mostly these masses are found incidentally, and if the unenhanced CT already describes that these masses are clearly benign or malignant based on the criteria that we already discussed, then there is no need to proceed to contrast enhanced features. But if these masses are indeterminate by the defined parameters, then in that case we need to do or proceed with the contrast washout characteristics in order to redefine these masses as whether they are benign or malignant. Thank you.
So the message here is you don't need always to do like the adrenal protocol or the contrast. So the guideline recommend that if it is clear, so you can just manage the patient based on the non-contrast CT. And the other question I got from the Q&As, so in our setup, still now there is no experience in doing AVS. So how do we approach if you have a hyperaldosteronemia in a patient above 35? Do you go for surgery without lateralization, or how to approach such patients?
So this is a challenging question, and this scenario would clinically be challenging. So I don't know, maybe Dr. Marta could reflect on it, but the chances of doing adrenalectomy on the wrong side is significantly high. So I would really reconsider the situation before deciding adrenalectomy in these cases. And even though the guidelines don't really give us a clear answer in cases where AVS cannot be done, maybe pharmacotherapy might be a better approach if malignancy is excluded in this case. But that is clearly my opinion, but I don't have any clear recommendation from any of the guidelines.
Yeah, like Dr. Elena said, it's one of the area of challenge in our setup for patients with hyperaldosteronism, with hyperplasia. So basically, if we cannot do a venous sampling, the other options will be radionuclide tests. Again, those we don't have. We can do positional tests. Again, we cannot also do that. But currently, what we are doing is, if we are suspecting bilateral hyperplasia, and if the image finding is like completely similar, there is no significant discordant in the right and left adrenal size and hyperplasia. Commonly, the treatment, we recommend a medical treatment, and most of the patients will have a favorable outcome with medical treatment. And if the patient is less than 35, less than 40 years old, with unilateral lesions, either adenoma or something, we don't have to do venous sampling, which is very good for us. We go directly for surgery. Otherwise, it is an area of challenge. We use either medical treatment, or if the patient is younger patient with a clear lesion on unilateral side, we go for surgery. The other thing we consider is the degree of hyperplasia. Either if it's disproportionately high in one side, you might consider surgery on that side, but basically, if it's hyperplasia on both sides, we opt for medical treatment. And if it's the younger patient with unilateral lesion, we opt for surgical unilateral adrenalectomy.
Other question is, what is the next step in management if a 30 years old patient is found to have adrenal mass on abdominal CT scan, and there is for other purpose, and there is no comorbidity?
Thank you, Saba. So what will be the next step in this young individual who has an incidentaloma discovered while imaging was done for other reasons? So in this case, we need to answer the two basic questions. So we need to characterize the imaging features to exclude malignancy. And the second thing we need to do is, even if there are no comorbidities, in this case, we need to exclude subclinical Cushing's and Pheochromocytoma with biochemical testing. And if that reveals a normal finding, then the guidelines, the AACC guideline recommend that we need to continue biochemical testing for Cushing's for the first 5 years. But if our clinical suspicion is very low, then we may not need to do further testing. But we need to characterize the imaging features for malignancy and do biochemical tests for subclinical Cushing's and Phew in this case.
Okay, I think the question is about how to approach a patient with an incidentaloma, and I think in the first presentation, and Dr. Elena also has answered it. So the first thing is it malignancy, and is it functional or not? So there is not a question but a suggestion. Since we have an interventional radiologist, we may try to do the AVS. I think in the future, it might be a good thing also to do the AVS. I don't see any questions, but if you want to add additional points, so I will give you a few minutes for both of you. Anything to emphasize?
So thank you, Dr. Saba. So the last question raised would be the key point that I would like to highlight. So every patient presenting with incidentaloma should be screened for subclinical Cushing's and Phew, despite the presence or absence of clinical symptoms, and we should also look at the imaging characteristics carefully in case they suggest any malignant features. So that would be the point that I would like to emphasize.
Okay, anything, Dr. Marta?
Oh, okay. I would like to thank everyone for joining for these sessions, and also the society for this opportunity to present the management of this pathology. Just as a final remark regarding the venous sampling, is there anything we can do as a society? Is there anything we can do in regarding incorporating the interventional radiologists to our, because this treatment is a multidisciplinary treatment. We have an endocrinologist, we have an endocrine surgeon. We need to also invite the interventional radiologists so that we can have a better standardized treatment in the future. If there is anything, any suggestion regarding this area, that how we approach the arterial venous sampling in the future, in our future practice, if anybody has an idea, so that we can incorporate this venous sampling in our evaluation and treatment options. If there is anything we can do, or if somebody knows the experience of this interventional radiologist in our setup in our country regarding this procedure, or how are we going to move forward in treating these lesions? Just an open discussion as a final remark.
Okay, thank you, Dr. Marta. I think like we will give a homework for the society to think about it, and also to include the interventional radiologist, because most of endocrinology surgeries need multidisciplinary teams. So it will be discussion for the society. So I don't see any questions. So for the participants, thank you for staying this long and then attending the presentations. All of you should fill the link for your name and then your email, so that you can get the SEME certificate. And also, as a reminder, so we have annual meeting, the second annual meeting, the SEME. So to come, register and come on March 7, which will be at Sheraton Addis. So register and come. So finally, I will thank the Society of Endocrinology and Metabolism of Ethiopia for preparing this SEME, and also the Yetena Weg for preparing for this platform, so that we can have a discussion on one of the endocrinology problems, that is adrenal mass. And thank you for both presenters, and thank you for the society, and then thank you for Yetena Weg. So we will wind our today's session. Thank you all, and have a good night.